How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're watching DNA Today, a multi-award-winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor and your host. In this episode, we have a discussion lined up focusing on a crucial aspect of genetic medicine, the intersection of genetics and cardiac health. Joining us are two esteemed guests who bring a wealth of expertise to the table. We're thrilled to have Julie, a seasoned laboratory genetic counselor, and Susan, a clinical genetic counselor who specializes in cardiovascular health. And their insights are going to really help to shed light on the intricate nuances of genetic testing and cardiac conditions. So throughout our conversation, I am really excited to explore a myriad of topics ranging from identifying genetic conditions with cardiac manifestations to navigating the complexities of genetic testing panels. And I think you guys have different opinions there, so I'm excited to launch into that. And we're really going to be diving in again to the profound impact genetic insights can have on patient management and treatment decisions. So we've got a lot to cover, but thank you both for coming on the show and taking your time to educate me and the audience.
Thanks, Kira. Thanks for having us.
And thanks for shedding light on this important topic.
Yeah, I love doing interviews where I don't know a ton about it, where I'm really learning with the audience. As the audience probably knows, I am a genetic counselor, but I don't work in cardiac. I never have. I've never even done a rotation in cardiac as a student. So this is really exciting just to learn about this. And it's such a growing area of genetics, genetic counseling in terms of people that go into this specialty. So I also expect as time goes on, there's going to be more boards questions related to it for those students listening. But, when I think about heart conditions, I think of two types. I think of like the structural differences, like a hole in the heart, and then differences in the frequency and the way the heart beats, like if it's fast, if it's slow. So I'd love to kind of start there in terms of explaining the difference between these two, and maybe if they have more specific names instead of me just like explaining kind of how I think of them. Julie, did you want to start us out just in terms of what these two types are as we start this conversation?
Yeah, absolutely. Thanks, Kira. So when I think about the structural differences, cardiac structural differences, I sort of think about anatomical differences. So the way the heart is sort of put together and any abnormalities in actually how it, the chambers, the holes in the heart, those ventricular septal defects that you talked about, atrial septal defects. Also thinking about not only the heart itself and the chambers, but also the blood vessels that leave the heart. Like, are they in the right position? Are they abnormally shaped, formed? Thinking about things like transposition of the great arteries. If you actually then break it down to like the aorta itself, like the integrity of the aorta, that tissue, if it's, sort of abnormal, which can lead to aortic aneurysms and dissections. So you've got kind of that whole structural side of it. And then more microscopic, if you want, you've kind of got the differences in the heart muscle. So whether that heart muscle is at the cellular level abnormal or structurally different than what it should be, either the muscle is thickened, such as in hypertrophic cardiomyopathy, the muscle is weakened, dilated cardiomyopathy, there's infiltration or scarring, which we can see in arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic cardiomyopathy. I think there's some other terminology out there that's kind of being updated. Restrictive cardiomyopathy. So the cardiomyopathies where the structural differences are really like right in this cellular level. And so then on the other side of things, if you've got the arrhythmias, then you've got abnormalities in the way that the heart beats, and that those arrhythmias, long QT syndrome, catecholaminergic polymorphic ventricular tachycardia, Brugada syndrome are all abnormalities, usually in problems in which the channels that control the in and out of the ions that make the heart beat, there's abnormalities there. So that either causes, really bad fast rhythms or sometimes slow rhythms that also can cause problems as well. The tricky thing about them too is that you can see arrhythmias, abnormal heart rhythms, happen in the cardiomyopathy conditions before you see signs of a structural difference. And your structural differences like your cardiomyopathies or the way the heart's kind of put together can cause arrhythmias. So there can be a lot of overlap, and it's complicated because we see overlap in lots of different symptoms and features amongst the different genes that cause these different disorders. And then, of course, last one that I don't want to forget about are the lipids, those dyslipidemias, which are more common, like relatively common, and also, an important one not to forget.
Yeah.
I don't know, Susan, if there's anything that I've missed there.
Yeah, I was just going to make sure you brought up familial hypercholesterolemia because it is a condition that I think is extremely underdiagnosed and undertreated, and we know that treatment can make a significant difference down the road for people with that condition.
Yeah, that's definitely one that we see often in family history, or we see signs of it in family history, especially for people that aren't even working in cardiac. I think it's really important that, as we have more and more specialties, genetic counselors then kind of go into these different specialties, but we still need to know the basics of each because we want to be able to identify that in patients. And, if I'm seeing a pregnant person and I see that in family history, I should be referring to you guys, right? So, it's all kind of working together in that sense. What are some key clues in a family history that may indicate these inherited cardiac conditions? Susan, are there things that you think of in terms of those key clues, red flags?
Yeah, I think that when somebody indicates that they have a family history of heart failure is a key flag for cardiomyopathies, or an enlarged heart would be another one. When you hear about family members that have pacemakers or defibrillators, that suggests that there might be arrhythmias. One of the trickier things we can struggle with is a lot of people are more familiar with the term heart attack, and so they report they have a family history of heart attack. And so trying to probe a little bit further in terms of distinguishing between heart attack and sudden cardiac arrest, asking if there's a history of high cholesterol levels, or if you hear the word bypass surgery or stents, those are things that suggest it is related to coronary artery disease compared to a cardiomyopathy or an arrhythmia. But we also dig a little bit deeper and ask kind of random questions that sometimes patients kind of look a little strangely at us about. We ask about if there's anybody in the family that drowned, if there was anybody in a car accident where the circumstances really didn't explain the accident, looking if, they had a cardiac event while they were swimming, which can sometimes be a trigger for cardiac arrest. And then I think the last one that we ask about as well is if anybody in the family had a child who passed away from sudden infant death syndrome, which can as well be sometimes explained by these inherited heart conditions. So any genetic counselor who sees those types of flags, digging a little bit deeper, looking if there's patterns of inheritance, but keeping in mind there's incomplete penetrance for all of these conditions. But those are the main things I think that kind of act as red flags for me.
And that makes it difficult sometimes to figure out, especially, car accident. People aren't thinking, okay, well, someone could have had a cardiac event that led to the car accident or the drown, so I think it's kind of thinking through it a little bit more. And you mentioned something that I think we should flesh out a little bit, the difference between heart attack and cardiac arrest. Can you explain that a little bit? Because I have no idea. So I'm assuming the audience is some people at least are with me there.
Yeah, so cardiac arrest is a rhythm problem. So it's the idea that the heart just stops and doesn't start back up again. So sometimes in families we see history of fainting where the heart stops but does start back up again. So that's what we think of when we think of a cardiac arrest. It usually happens quickly. There's not a real symptoms that pre-present with it. And then a heart attack is when there's a blockage in the blood flow, and that's what leads to the heart stopping. And that's more related to like familial hypercholesterolemia versus the cardiomyopathies or the arrhythmias.
Okay, that makes more sense. I think that's helpful for people to kind of understand the difference there. And as we've kind of been alluding to, unfortunately, cardiac conditions are often identified after family members have died or one family member has died from a sudden cardiac arrest. And as we're going to get into, cardiac genetic testing can be helpful in identifying risk members, family members also at risk, and possibly allow for intervention. So that's a big part of cardiac genetics. But in order to know what genetic change we're looking for, we often need to do genetic testing on someone that has already passed away from this. So I think this is very different in terms of ordering genetic testing on someone that's already passed away. What are some of the challenges in labs to be able to do this? How can we improve in this area? Julie, I know you're kind of more on the lab side.
Yeah, I think it's a really important issue that we need to talk about because the way that we have to be able to even be able to perform the testing to get people a result to be able to work with. And if I take a step back from that, in order to be able to perform the test, we need a sample that is going to be of good enough quality for us to be able to run that test. And that is probably one of the biggest problems with these cases of sudden unexplained death or sudden cardiac death, where the death happens and then the sample that is saved is not one that is amenable really well to genetic testing, more often than not, really sadly. When a coroner or a medical examiner would perform an autopsy, often they would save some tissue in something which we call formalin fixed paraffin embedded blocks, which the minute that formalin touches that tissue, it just really fragments the DNA and really impacts the way that we can even utilize that DNA to be able to go on and do proper genetic testing. That being said, there are, you can look in the literature and there are some groups who have been successful in extracting DNA from paraffin embedded formalin fixed tissue. But, a commercial lab like Blueprint Genetics, like other ones out there, are not always routinely being able to do that. The method is tough. And even when you get that DNA, or even if someone else were to extract that DNA and we would be able to have it in the lab, it's really hard to work with. And often the quality is so poor. So that, getting an appropriate sample, sometimes we can use a blood spot to try and get adequate DNA. You need a lab that's validated to be able to do that. Sometimes if blood happened to be collected in a tube that is maybe a little atypical, but we potentially could try and use it, that might work well. It's just, it's not often that we get that nice clean sample that we need, which is blood in EDTA or a purple top tube, to be able to perform the testing at a level that we really need to be able to get a full answer for the clinicians and for the families. And, the other struggle with that is that we kind of have one shot often, right? Like there's that one sample and we need to make sure that the test we're running is has all of the genes that we want to be considering for this particular patient. In an ideal world, there's kind of a way where you can kind of do perhaps a stepwise fashion where you maybe test for the arrhythmias first and then the cardiomyopathies and then maybe something broader than that. And then maybe the whole exome, or you do it on a whole exome backbone. I know I'm maybe getting ahead of myself here, but I think the point is it's really a challenge because A, can we find a good sample? B, are we choosing the right test? If we have only one shot with the technology we have today, it's not always easy to bioinformatically kind of unmask things to be able to find an answer. So that's kind of where the lab struggles a little bit. Interpretation, which I think Susan can speak to the outcome of this too, is that the interpretation can sometimes be challenging because we might just have the information that we receive is an individual died suddenly, no cause of death identified on autopsy, fully clean. And that can make the interpretation of genetic test findings more challenging, right? So yeah, that's from the lab side of things.
There's so many factors that go into it. And then, I don't think we have time for it, but also just the aspect of, okay, you're testing a sample of someone that's already passed away in terms of insurance and all of that, and who is getting this information. But if we do find a variant and we say, okay, this is causative, this is a pathogenic variant, in those cases, who should be tested next in the family? Why is it even valuable to have this information? Because you're talking about how precious these samples are and stuff. That's for a reason. Are there types of interventions that exist? I know, Susan, you were often talking about this.
Yeah, so I think the short answer is all biological relatives should be offered testing once we find a genetic variant. And what I would add to that is all biological relatives, regardless of age. So historically, there's been some question about whether or not testing should be offered to kids because a lot of these conditions generally present during adulthood, but testing should be offered to everybody. And the reason that is because there is a lot of variability in how these conditions can present. They can present as early as infancy, childhood. Average age tends to be for a lot of them in the 30s, but we can still see people presenting 60s, 70s, and 80s. And so that also kind of highlights that testing can't be, or follow-up can't be just a one-time event. It needs to be done on an ongoing basis. And so once somebody's identified to carry a familial genetic variant causing one of these conditions, then for a lot of them, it requires cardiac screening with perhaps echoes, ECGs, stress tests, Holters, that sort of thing, with the goal that if we can identify family members earlier, prevent these incidents like cardiac arrest or extreme heart failure, then we can treat them and manage them earlier. And there is research showing that people do better when we make those diagnoses earlier. And so that's really in genetic counseling, one of our main aims is to first, find the explanation or the genetic cause, but then help families communicate that information with their relatives.
Yeah, that's really helpful. And I think one of the big areas is that we do test children. There's a lot of areas of genetics where we say we want to wait till that person is 18 so they can be part of that informed consent process and say, yes, this is something I want. I think about especially in the cancer space. But with this, there, as Susan, you're saying, we may have interventions and screenings and things that we can be doing during childhood. That's really important. And you guys talked about at the beginning with family history of sudden infant death. And sometimes that can be, one of those red flags that we think about in terms of family history of could there be a cardiac condition in the family. So I think that's kind of one of the things that as genetic counselors, we try to, learn the rules, but then we got to learn the, rule breakers in terms of that. And I think testing kids is one of them here. And I think along with that, thinking about, we've talked about the cardiac conditions, but there are also genetic conditions that can have some of these, like I think about like as a symptom. Are there ones that you guys think about in terms of, I think about Marfan syndrome, some that we should be aware of and remember, these can have cardiac symptoms as well.
The one condition that I have found patients that have it that isn't always on the front of my mind is mitochondrial conditions. So as a side effect, we can see cardiomyopathy with mitochondrial conditions. Most of the time you'll see other symptoms that go along with that. So it's not unusual to see hearing loss, diabetes, that sort of thing for the mitochondrial disorders. Those are also very common things we take in a medical history. So kind of piecing those things together and making sure that you're considering if the testing you've requested includes sequencing of mitochondrial genes.
Huh. Yeah, not something that I would think about right away. Yeah, that's interesting. And I want to circle back to what we talked about earlier. Julie, you were mentioning genetic testing in terms of, okay, what panel do we choose? Do we go with a broad approach? Do we go with a more targeted approach? And what goes into that decision-making in terms of mindset and everything? I don't know, Julie, if you want to elaborate on your answer before we hear from Susan.
Yeah, I think, thanks. I definitely can go first, but I just, sitting in the lab, it's a completely different perspective, right? Because, all we want to do, and just like the clinician, all they want to do is find this answer for the family. And for me on the lab side, all I can think about is what if it's, what if they've tested for one small panel and the variant is actually in a gene that the presentation is actually very atypical and it's in a gene like all the way over here that we didn't even consider, and so I often, my bias is throw something very broad at a situation. Of course, it depends on the patient and what the clinical presentation is, right? If it's a nice tight diagnosis, then probably makes sense to keep things pretty targeted. But if it's something broader, if it's atypical, if we're talking about a pediatric patient, for example, with cardiomyopathies, there's so many underlying possibilities here. So I think most people may consider something actually quite broader in that perspective, but I don't know. I think we're constantly finding more gene disease associations. There was actually recently there's a series being put out about recessive causes for cardiomyopathy, um, just the one that we have on one of our panels, NRAP and LMOD2 and PPA2, which are, you don't often think about recessive causes for the cardiomyopathies and arrhythmias often. So I just always wonder, is there maybe a bit of a more obscure gene here that could be at play that we might miss if we don't, if we don't keep that testing broad enough. That being said, what Susan is probably going to say is that, if you find that variant in a gene that's obscure, it's going to be a VUS, a variant of uncertain significance. And now I have to explain that to the family. And that's a whole other thing. So for me, it's really exciting to be able to find like a very suspicious VUS in a candidate gene, but I recognize that is not always, I shouldn't say a candidate gene, or maybe an obscure gene or a preliminary evidence gene. I think that's really, sort of exciting from the lab point of view, but when you bring it back to the family, I mean, I'll let kind of Susan say her piece about that, but my bias is sort of going bigger, unless there's a way to sort of, as I think I was alluding to earlier, bioinformatically sort of opening things up, and always using kind of that, not using more than one sample, like in the cases of deceased patients where the sample is precious, for example. So my bias is bigger, and but that's where I stand.
That makes sense on the lab side. You're like, let's look at as much as we possibly can. If there's a VUS, we could potentially follow up with that. But then, Susan, on the clinical side, that's tough, because if you have a VUS, explaining that to patients, as many of us do in many fields of genetics, that's hard to explain. But also then the follow-up in terms of, okay, is this a sample? Like, let's say it's from someone that has passed, then we can't really do too much follow-up. I mean, how does that look on the clinic side? Because I think you're the opposite. You're kind of more like, let's start with targeted testing.
Yeah, I think that my default is targeted, but I will completely agree with Julie that a lot of the times you have to balance. I never want to feel when I get a result back, and if it's negative, that I should have gone broader. So it is really looking at the patient situation. But interestingly, I feel like when we sit down with patients and kind of review the VUSs, a lot of times they're pretty good about understanding it once they hear an explanation. But once that's on the patient record, I feel like there's other healthcare providers that take a quick glance at a result. If it's in a gene that causes cardiac conditions, then they make the assumption that this child or person has this condition, and that's not always the case by any means. And the other thing, when we do broader panels, we also can sometimes find patients are carriers for recessive conditions, and that are completely unrelated to what they're there for. And I find that they tend to be a big distraction during the counseling appointment. They end up taking a lot of time to explain, and then we kind of lose purpose of why we were actually doing the testing in the first place. So I do start with a more targeted approach, and then I say, is there anything in the family history or with the patient's presentation that makes me want to go broader? And certainly for sudden cardiac arrest cases, we do take a broader approach. Definitely, if there's anything, a multi-system involvement, then we look at a broader approach. But I do definitely see the impact from the patient perspective, and also kind of looking at their bigger healthcare experience and misinterpretation of those VUSs.
This highlights how important genetic counselors are in this space to be able to explain. Susan, as you were saying, of just going through a VUS, like you're like, okay, that is a hard thing to understand. But if you have a healthcare provider that is trained in genetics and that's a really good communicator that can explain that to the patients and their family, then that's great. That person is much better to move on in terms of what needs to happen now in terms of screening, other types of intervention, treatment, whatever that looks like for that certain condition. Or, hey, check back in a few years and maybe this variant will be reclassified, where we say now it's actually, like a mutation, a pathogenic variant, where we say this is actually causative of the condition versus, oh, this is just a change that everybody's a little bit different, in terms of like human diversity and everything there, where it's like it's benign. So I think that's really important. But do we have enough genetic counselors in this space? I mean, it's also not just the educational perspective, but it's the emotional, psychological aspects. I mean, your job is really tough, because you're often talking with families that have experienced trauma in terms of people passing away very quickly and suddenly.
Yeah, well, I think the short answer is no, there's not enough genetic counselors in this specialty, and that's not different from any other field of genetics. There's just not enough counselors to deal with all the genetic issues that are arising with the new technologies that are out there. So I think that there's a lot of new approaches that are being taken because there isn't necessarily enough counselors to see patients for that pre-test education and then the post-test experience. And so I think there's a very new approach in terms of developing some resources for other healthcare specialists, cardiologists, to provide them with tools so that they can do a lot of the pre-test counseling, forming strong relationships with the different cardiac groups so that if they have questions, they can reach out. And then there's more recently a bigger focus on that post-test counseling. In where I work, we still do pre and post-test, but in a lot of places there's more focus on just seeing the patients once a VUS or likely pathogenic or pathogenic variant's been identified. So I think as time has gone by, we're a relatively new field. Really testing for cardiac genetic conditions came up in like the mid 2009-ish is kind of the age that I think of. So we've followed a lot with what's happened in cancer and starting to try and do everything ourselves, and then developing different service delivery models to address the patient population. So looking at what we can really add as genetic counselors, and a lot of that psychological counseling with around results, dealing with the complicated test variant or the variants that we identify, and then that family communication piece within families and helping them come up with strategies to get the information out to their relatives so we can avoid one of those tragic events that we see far too often.
And as you said, this is a relatively new area of genetics. Genetics in general is pretty new, right, in terms of healthcare. But then when we look at cardiac genetics, I mean, you're talking something like, 15-ish years ago. So that's not very long. So with
and the uptake of genetic testing in this space is not near where it should be. I think everybody would sort of agree with that. There was a paper that came out recently that sort of showed how low the uptake is for patients where it's just a clear indication where genetic testing would be indicated. So all the more reason for, emphasizing what Susan's saying about finding different resources for patients, because if we can try to get everybody tested that needs to be tested, it's just going to create so much more need for everything that Susan just mentioned. Sorry to cut you off there, Keith.
Oh my gosh, no, that is so important. I think that's a really, really astute point. And I mean, are there other emerging trends, developments in genetic testing that are happening that you're finding that are particularly promising? What do we expect for the future as we kind of close out today?
So one area in cardiac genetic testing, I guess we touched a little bit on this, how broad of testing should we maybe be considering, and where are the genetic causes in those families that so many clinicians like Susan has been following for years? Genetic testing has been negative. Where is the explanation for those families? And what test is going to, it's possible that we may not find it, but I think that there are areas that we haven't looked at, sort of the non-coding deep intronic variants or non-coding regions. I think we see more and more of these variants kind of pop up as being deep intronic non-coding regions. They are so hard to interpret because you need, follow-up functional assays, RNA studies. I know some groups are doing, follow-up RNA studies in the cancer space, but not that I know of really in the cardio space. And we need to, I think, try and look at those non-coding regions, and how we might do that is maybe through a genome. That genome needs to take into consideration all those non-coding regions, analyze them, interpret them, and we have to find a way to be able to really be able to follow up that and be able to give people helpful information. I think doing testing that already includes some non-coding and deep intronic variants is really important. It's hard to keep that up to date. Labs need to be on the ball and adding those variants as they are coming up in the literature, looking at them, making sure that, if we're going to be including it and reporting it, we need to be able to be sure of what the evidence that backs it up. Blueprint Genetics does have some non-coding variants and deep intronic variants on their panels. So I'm hoping that those regions down the line are going to, maybe solve some of these families. So that's an area that I'm really excited and interested about, that's upcoming. And then, of course, if you think about, a push for gene therapies, or there's more clinical trials, I think there's more and more happening in this space, which again, just really emphasizes the need of finding that genetic explanation in as many families where one exists. It's kind of where I'm excited about in the future.
Yeah, especially with clinical trials, oftentimes the eligibility criteria says you need to have genetic testing that shows this. So if you have the genetic testing, then you may be eligible for some of these clinical trials. And, I think that's a really important area that I don't see talked about as often as I would like in our field. Susan, any other thoughts as we kind of wrap up today?
Yeah, I think the biggest excitement I have right now is around these gene therapies. In our field, in the last year, there's been a number of trials that have started up for various different conditions, and genetic testing plays a key role because without knowing the specific cause, you can't design a gene therapy that's going to be effective. So they go hand in hand, and yeah, we've seen gene therapy in a number of different areas, and now seeing it come into our arena is very exciting, and I look forward to seeing some of the outcomes of those trials.
Yeah, definitely.
Yeah.
I'm looking forward to just seeing how this field expands and how much we're able to learn. And just as we kind of talk about with genome sequencing, just that is really it has been taking over in terms of how much information we can learn. But then the more we look at, the more we have to learn. I think it's, especially those deep intronic variants and everything that, as soon as you learn a little something about genetics, then it's like, well, I realize how much we don't know and how far we do have to go. But it's a very exciting field. We haven't done a cardiac episode in a number of years. So I'm just kind of blown away with how much has really improved in the last, I don't know, maybe that was 6-7 years ago. So this has just been really enlightening. Susan and Julie, thank you so much for coming on and sharing your wealth of knowledge with me and the listeners. We'll probably have to revisit this in a couple of years or even sooner, just with how fast things are changing. So thank you both.
Thank you.
Thanks, Kira.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.
They're all made of DNA. We're all made of the same chemical DNA.